I'm going to be talking about assisted suicide for Group 3, Cameron Schultz, Anifa Sofa, John Iverler, Savannah Reininger, Maya Seymour, Sydney Early, Kimberly Stewart, David Taylor. History of physician-assisted suicide within the United States. According to the advocacy group Compassion and Choices, Oregon became the first state to approve an aid in dying law in 1997. Voters approved the Oregon Death with Dignity Act ballot measure to initiate this act. In 2008, voters in Washington approved a similar death with dignity ballot measured by a 59% to a 41% margin. History continued. In 2009, the Montana Supreme Court acknowledged a lower court decision that ruled it is not against Montana public policy for a physician to initiate medical aid in dying to a terminally ill patient. In 2013, Vermont became the first state to approve an aid in dying policy through the means of legislation involvement. Finally, for history continued, California state lawmakers took a similar action in 2015 when they approved the End of Life Option Act. And in 2016, more states adopted physician aid in dying laws. Physician practice perspectives. Political importance of physician-assisted suicide. With the world changing, so are the thoughts of whether or not physicians should be allowed to aid an ill patient in dying. And that comes more or less, I think, with the ethical issue dealing with physician-assisted suicide, because the states now allowing physician suicide include California, Oregon, Washington, Hawaii, Montana, Colorado, Vermont, and Washington, D.C. Like I said, I think the main issue for physician-assisted suicide is the ethical issues that come along with it. Thoughts about physician-assisted suicide. Physician organizations like the American Medical Association, which is the AMA, and the American Academy of Family Physicians, which is the AAFP, have traditionally opposed physician-assisted suicide. However, these organizations have decided to take a hands-off approach in states that have passed laws allowing the practices. And those states, again, are California, Oregon, Washington, Hawaii, Montana, Colorado, Vermont, and Washington, D.C. Thoughts about physician-assisted suicide. Since aid in dying is still a policy that is regulated on a state level, the leadership of both organizations, the AMA and the AAFP, leaves the decision to the individual physicians in the state that chooses to adopt death with dignity laws. This means the physician is allowed to perform assisted suicide in those states if they think it is necessary and beneficial to the patient. And those physicians in those states that accept the death with dignity laws must comply with the patient's wishes that they choose to proceed with physician-assisted suicide. Facts about physician-assisted suicide. A person has to be capable of making his or her own decisions and oriented enough to understand what he or she is asking for when they are asking for a physician attempt to end his or her life. The physician himself or herself must include and provide all alternatives as hospice care itself. This includes pain management and much more. In some states, there must be a representative of the family that is notified, and that representation person, whether it be family, must be present in that state that the patient is attempting physician-assisted suicide. Facts about physician-assisted suicide. The law protects the doctor or physician that participates in the patient's decision for physician-assisted suicide. In all other states, the first oral request to the physician is usually a 15 to 20 day waiting period. And that's for the state that physician-assisted suicide is legal in. The second request is an oral request to the physician. After there is a 24 to 72 hour waiting period between writing request and writing of the prescription for the physician-assisted suicide drug. Other facts about the physician-assisted suicide. There is an ethical battle when it comes to assisted suicide. The reason most of the states don't support the assisted suicide battle is because of the big ethical issue that comes with it. The start of the assisted suicide started with sick newborn babies. So why is physician-assisted suicide so important now and becoming more important with patients and physicians? Medicine is considered to be part of healing, the relieving of pain and suffering, and the prolonging of life. That's why medicine was brought about. The debates regarding euthanasia and physician-assisted suicide, which is PAS, in medicine are geared towards the role of physicians in the decision-making of the patients during the end-of-life period when they are suffering. Individuals in favor of euthanasia and PAS, physician-assisted suicide, argue that the potential for these actions are humane and merciful in respecting an individual's request to end his or her own suffering. They also believe someone should not have to suffer immense pain that is unnecessary. So they're believing in physician-assisted suicide for someone who is suffering, for someone who has a terminal illness that is just going through a ton of pain. For all those who oppose, however, in contrast, those opposed to euthanasia and PAS, which is physician-assisted suicide, argue that ending a life is morally and fundamentally unacceptable in today's practice. These individuals believe that the use of assisted suicide is never an appropriate way to end a person's life. So you've got physicians who accept it and physicians who deny it, or who don't like it. And those physicians can be in the states that accept physician-assisted suicide, and they can be in the ones who don't. You got a mixed match of both. Where does this leave us? Although euthanasia and PAS, physician-assisted suicide, are fundamentally different, they both attempt to give individuals the freedom to determine when they will terminate their own lives to avoid extending an unwarranted suffering. PAS, physician-assisted suicide, is defined as prescription of lethal means to end a life by a physician, also usually using a drug. The physician must act alone when using a prescribed lethal means. Means nobody can help the patient make the decision. The patient has to be able to make the decision on his or her own. That's why it's so important for them to be capable, alert, and oriented for them to make this decision. And if they are not, we as nurses and physicians cannot allow them to make that decision because they might be reacting irrationally if they're not alert and oriented times 4. Legal requirements for physician-assisted suicide: a patient must be 18 years or older, must be capable of making healthcare decisions for oneself, for his or herself, diagnosed with a terminal illness and has 6 months or less to live. The attending physician must admit that the above criteria are met, which is the patient's 18 years or older, they're alert and oriented times 4 and can make decisions for themselves, and they've been diagnosed with a terminal illness that has 6 months or less to live. The patient ultimately administers the medication. So the physician writes the order for the medication, and then the patient takes the medication, and leads to physician-assisted suicide. Medications. The class of medications used in assisted suicides are barbiturates. These barbiturates allows activities in the brain and the CNS, which is the central nervous system, to slow down. Seconal barbital capsules and phenobarbital, or the Nembutal, have been either used alone or in combination for assisted suicide. None of the drugs are used for assisted suicide or lethal injection is FDA approved for lethal purposes. So we use these drugs every day in different manners, but we don't use them here in Tennessee for assisted suicide. The FDA has not approved for these drugs to be used for physician-assisted suicide for the lethal purposes. Impact on insurance. This is really, really big because some insurances pay for the assisted suicide and some do not. Assisted death saturated do not specifically specify who must pay for the services. Individual insurers determine whether the procedure is covered under policies. Federal funding, including Medicaid and Medicare, cannot be used for services or medications under assisted suicide laws. So the big two federal funding ones, Medicaid and Medicare, do not cover physician-assisted suicide. So that means it has to come out of the pocket of that patient or the patient's family to cover the medicine that will assist the patient in physician-assisted suicide. So individual insurers, such as big insurance companies, might actually cover the physician-assisted suicide. It just depends on what your insurance is and what it covers. This is a major slide. It's telling us all the terminal illnesses, well, some of the terminal illnesses for people choosing physician-assisted suicide. I would say the number one reason terminal illness would be cancer. And there's cancer, AIDS, leukemia, Leschen's-Knifelin syndrome, also known as juvenile gout, Ebola, hemorrhagic fever, are other terminal illnesses that are reasons why people choose for physician-assisted suicide. Here are the references for slides 11 through 14. Barriers to assisted suicide. Terminology poses a problem, which is aid in dying. Lack of support from major medical associations, because like we said, not every state or organization supports physician-assisted suicide. And the lack of support because people fear doctors would abuse the law. So barriers, that would be a major barrier. So we would have to create laws that would prevent doctors to abuse physicians-assisted suicide in the states approved and that are going to be getting approved. Other barriers are family conflict about best action for the patient, patient family fear of death, cultural or religious beliefs, financial, language, lack of hospital and palliative care services, lack of provider knowledge of hospice and palliative care. The lack of provider knowledge of hospice and palliative care, the provider may not know of all the options that hospital or general area has to give for hospice or palliative care. Some places even lack hospice and palliative care services, so that would be a major barrier for this. And language, if they don't understand. Financially, we talked about the insurance. Some insurances cover and some don't. We talked about the two major ones, Medicaid and Medicare, that are federally funded, do not cover physician-assisted suicide. Some major insurances may cover the care or the cost of the physician-assisted suicide. It just depends on who the coverage is through and what your policy consists of. I would say the two major barriers would be family conflict about the best action for the patient and cultural and religious beliefs. And sometimes they can go hand in hand, but those two would be the two greatest barriers when having to deal with the physician-assisted suicide. And of course, the family and the patient both probably have a fear of the death. Actions for assisted suicide. The patient has to be 18 years or older. Request is voluntary and informed, so the patient has to tell the physician that he or she wants physician-assisted suicide. They have to have a terminal illness with 6 months or less to live, and be informed. They have to be informed of hospice, palliative care, pain management, anything that can help them live the best of life they can with the time that they have. They have to be informed about before physician-assisted suicide is considered. The patient, of course, has to be capable of making and communicating healthcare decisions. That means they have to be alert and aware, which means alert and oriented times 4. Attending physicians and counseling physicians have determined persons suffering with a terminal illness that results in death within 6 months, which is what we just said a few minutes ago. So implementation of assisted suicide. So it goes to the Supreme Court, then they can refuse to hear the case, or the Supreme Court can accept the case but avoid addressing the legality of the physician-assisted suicide by ruling that federal agency has the right to prevent the implementation of it through the Controlled Substance Act, accept the case, and specifically address the issue if it will be legally permitted in the country, if it's authorized by the state government. So the Supreme Court then can refuse to hear the case, accept the case but avoid addressing the legality, or accept the case and specifically addressing the legality of the issue. And the implementation of assisted suicide can be legal upon state approval to reach a final decision. And here is your references for slides 15 through 18. Death with dignity comes about when we're talking about physician-assisted suicide. Death with Dignity is a national organization based in Oregon that is a major supporter of physician-assisted suicide or physician-assisted dying or aid in dying. It supports death with dignity as an end-of-life option for a certain terminally ill people to voluntarily and legally request and receive a prescription medication from their physician to hasten their death in a peaceful, humane, and dignified manner. The organization claims that terms such as assisted suicide or doctor-assisted suicide are very misleading. Death with Dignity National Center is a 501c3 nonprofit organization. This organization expands the freedom of all qualified terminally ill Americans to make their own end-of-life decisions, including how they die, promotes death with dignity laws around the United States based on groundbreaking Oregon models. This organization provides information, education, and support about death with dignity as an end-of-life option to the patients, to the family members, to legislators, to advocates, to healthcare and end-of-life care professionals, to the media, and to the interested public. The organization also mounts legal defense of a physician-assisted dying legislation. So this nonprofit organization is supporting terminally ill patients who are interested and who wants to have physician-assisted suicide. Death with Dignity continues. The organization was heavily involved in the Oregon Death with Dignity Act, allowing those who are terminally ill to hasten death and consult with their physician and under strict safeguards, which means that the organization has educated them and supported them in physician-assisted suicide, not led them there, but educated them and helped them through the process. And it is also saying that they have to do the physician-assisted suicide underneath their physician's orders and reviews, because the physician has to be there to monitor the patient and make sure the patient is taking the correct medications. And this passage made Oregon the first U.S. state and one of the first jurisdictions in the world to officially legalize medical aid in dying. They authorized, passed, and defended this law. And that all, again, was to help people if they wanted to have physician-assisted suicide. Death with Dignity continues. Death with Dignity claims to have spearheaded the effort that led to the passing of death with dignity statutes in Washington, Vermont, California, and Washington, D.C. The passing of death with dignity statutes in Washington was in 2009, the Vermont was 2013, California it was in 2016. In Washington, D.C., it was in 2017. Death with Dignity continues. The organization's website has a wealth of information on the subject and guidance for those eligible states that want life-ending medications. On there they have information for the patients and the physicians, education, questions that you can go on there and review if you want guidance and you're eligible or the physician is in the state that physician-assisted suicide is legal in, to help guide you guys in physician-assisted suicide. They list the eligibility criteria one must meet to use the law, as well as many different statutes of the law. They also list information that permits to insurances and statistics on how people use the law and how many physicians use the law. The opinion of the physicians on the law, excuse me. In a minute, we'll talk about some statistics that come along with physician-assisted suicide. And we did talk about the information that pertains to insurances, because some cover it and some don't. It seems like the major insurances are mainly covering those, and the lower insurances and federally insurances are not covering the cost of physician-assisted suicide. So that's having to come out of the family members or the patient's pocket to cover the drug for physician-assisted suicide. Here is Death with Dignity continued. The website states federal funding such as Medicare and Medicaid cannot be used for services under those laws, which we were talking about previously. So those two major federal insurances do not cover Death with Dignity, as the organization would say, or physician-assisted suicide. It depends on the insurer whether or not the law is covered by insurance, and mainly the major insurances cover it. If not, it'll have to come out of the patient's or the family's pocket to pay for that medication. In 2016, here's the statistics I was talking about. In 2016, a total of 204 terminally ill patients in Oregon used that law. And in 2015, 213 people in Washington used the law. The website claims that those that use the law usually have excellent health care and insurance, and are also well educated. So like we were talking about, they probably have a higher health care and insurance company, and the well educated could be from them having result in them having higher health insurance, and so therefore it is covered for those people for a physician-assisted suicide. 2 out of 3 individuals over the age of 65 with a median age of 72. And the website also claims that according to a 2016 Medscape survey that 57% of physicians supported the law. So in 2016, there was 57% of physicians supporting the law, an increase from 46% from 2010. And that's a lot. That's an 11% increase in 6 years of physicians supporting, all physicians supporting physician-assisted suicide. So here's our references for slides 20 through 25, and just an overview of what we covered. The states that have legally accepted physician-assisted suicide is California, Oregon, Washington, Hawaii, Montana, Colorado, Vermont, and Washington, D.C. are all the states, and Oregon was the first state to receive death by dying or physician-assisted suicide. And from 2010 to 2016, there was 11% increase in physicians that are supporting physician-assisted suicide. And that's big. And for somebody to be eligible for physician-assisted suicide, they must be over the age of 18 or over. They must be able to competent and to make their own decisions, which is alert and oriented ×4. They must be able to tell the physician on their own. Nobody can push them in making that decision or tell the physician for them. And they must have a terminal illness that is 6 months or less before they pass away. Most people do it because they're in pain from, a couple examples would be AIDS and cancer, were the big ones that we discussed. And I would say the big issue about this physician-assisted suicide in general, is the ethical issue that comes with it, and how the patients feel, how the patient's family feel about it, and religious feelings. But if you have any questions, please feel free to email anybody in our group. Also, I will be attaching a discussion questions to go along with this PowerPoint, and we've come up with 2 papers, a material discussion handout. One's a quiz that you can go take after you get done with reading or listening to our presentation, and the other one is a fact sheet about assisted suicide. And once again, if you guys have any questions, feel free to email anybody in the group, and we'll be glad to answer them for you. Thank you so much.